did in setting out this project is that we were conscious that often when we undertake analysis, we don't look at the vulnerable populations until the end and we add them on. So we embedded into our analysis early about who are our vulnerable populations and do they have different access patterns or presentation patterns to the rest of our population. And the assumption is that especially some vulnerable groups are more likely to substitute GP care with ED care. Firstly, we looked at residents by cultural background, and we found that residents that presented to ED that actually identified as Aboriginal did not have different triage 4-5 presentation rates or travel patterns to the rest of the population. The Aboriginal population were no more likely to present with a triage 4-5 condition related to alcohol or drugs or to a mental health condition. So it's one of the Aboriginal communities that are often highlighted as presenting to ED more. We also looked at residents, given that we have high proportions of culturally and linguistically diverse. We looked at non-English speaking background patients, and we found lower triage for presentation rates than the rest of the population. However, when we control for age, given that we know that our non-English speaking background populations are typically older, they actually had higher utilisation rates than the rest of the population. We looked at refugee access patterns. Again, our two Medicare locals have high settlement areas for refugees. And we looked at these patients from recent refugee countries of origin as identified by the ABS. Here we found much higher utilisation of emergency departments and higher again after hours than the rest of the population. This increased again for both cultural groups when presenting to specialist hospitals in hours, but decreases significantly after hours to the specialist hospitals. And I'll highlight that in a minute. Now, lastly, what we found when we went through and we found those high rates of 0 to 4 presentations, we decided to look at that in more detail. So when we looked at the whole of our populations from across both regions, we found that 49% were presenting to our study hospitals and 70% were going to specialist hospitals. 92% of that 70% were actually to the Royal Children's. And that is because the Royal Melbourne and St Vincent's don't typically see children, and that the Royal Children's Hospital is their home. We looked here again at Aboriginal residents aged 0 to 4 and found here that they were less likely to use our study hospitals or the specialist hospitals. And again, we're talking about really small numbers. Looking at non-English speaking background and refugees there, what you can see compared to the 70% of the whole population, non-English speaking background are 81%, so they're more likely to use specialist hospitals, and that increases again with refugees up to 86%, but again, small numbers. We looked at paediatric presentations by years to see was it an issue of the 0 to 12 months or was it an issue across all of the age years, and we found that the percentage of triage 4-5 presentations increases with age, however the number of presentations decreases with age. What we also found here that 0 to 4-year-olds, as someone mentioned before, actually did have the highest did not wait. So they were more likely not to wait for treatment than any other age group, and in fact did not wait actually decreases with age. Of all the 0 to 4 triage 4-5 presentations of our residents, all of them had a treatment time of less than an hour. So if we remember back to the very start when Norman highlighted the 3 operational definitions of a primary care type presentation, if we use that most stringent definition of triage 4-5 plus a treatment time of an hour, all 0 to 4s fit that definition of a primary care type presentation. Recommendations, sorry. So our recommendations here is to provide information and education supports to residential aged care facilities and health and community care providers about accessing primary care services. That might seem an interesting recommendation given that I didn't highlight the elderly data, but I could do another whole session on elderly data. Our other recommendation is about to identify and promote practices and pharmacies that are identified as speaking languages other than English or have registered for Indigenous health initiatives, and that we need to research culturally and linguistically diverse local populations' primary care access patterns, preferences and health beliefs. We know that health literacy plays a significant issue in health-seeking behaviour. We want to analyse approaches hospitals take in treating primary care patients with mental health concerns and promoting best practice models. Again, mental health patients are a vulnerable population, but I haven't included them tonight. We do need to build that evidence base regarding Aboriginal and Torres Strait Islander people's preferred health-seeking behaviours and their local community perceptions. We know that they have preferences on where to go to seek care for the cultural appropriateness. And we also need to research the primary care needs of people with a disability. So on that last one, people with an intellectual disability are more likely to be allocated a triage 4-5 condition as well, and it's 72% a triage 4-5.
When they might not be.
When they may, yeah.
Jim? Strongly support the recommendations, and in terms of the research, particularly around non-English speaking groups, Aboriginal, people with an intellectual disability, etc. There will be a lot of knowledge base and good practice base within particularly our publicly funded services like local government community health that do that job well. In relation to mental health, we would strongly support consistent approach across the acute sector, because that's one of the frustrations in terms of different practices, particularly in the mental health area. And in relation to people with intellectual disability, it's probably less, I would suggest, their primary care needs. It's more about access in practice. People with intellectual disabilities generally have the same health issues, but it's more about how you actually work with them.
Just one issue on the data, and recently BMD has been looking at the way Aboriginal patients nominate to health services or are identified by health services, and there is a real problem, and we don't know the denominator really, because BMD doesn't correctly capture that.
So so the question is, did you get your question answered about refugee health? You asked Sarah.
I suppose I'd just like to make a little point that, in fact, it's very hard to identify refugees in the current data sets. So we're making a lot of assumptions to say that coming from refugee-type countries, that they might or might not be refugees.
Year of arrivals. Capturing year of arrival is very important as well as country.
Right.
Yeah, because many countries have a health system where you do self-refer to a hospital for,
And likewise, I'm saying intellectual disability, I'm not sure if you'll be able to identify people.
Yes. Good point. But it is a nuanced picture you present here of, in some groups, undercare relative to their need. So there's an inverse care going on. Some people, even with the elderly, I think your previous data, you were probably underserving certain groups. But some groups, not necessarily the case, who might be vulnerable. So it's not one size fits all. Is that what we're saying here?
Definitely.
Yes.
Yes, so I'd like to just
concur with that. It's not a one size fits all, because I think this comes out very strongly in all the work that you've done in this exercise, and that it's a complex problem. It's going to require a set of complex solutions, and I think that's what's really helpful for that, is that there are particular age cohorts, particular groups that we need to understand better, and they'll require a particular response. And I go back to the consumer perspective as well. We've got the data now on people's behaviours. I think then adding to that what people say about their perceptions would give us a really good picture and help us to think about where to from here. But I was also interested in Gareth's point about we tend to think about either it's ED or it's the current services as it stands, and particularly the reliance on GPs. I was interested in perhaps Gareth explaining a bit more on what he was talking about in terms of urgent ambulatory care centres as an alternative to emergency departments.
Well, around Cambridge, the GPs from numerous practices were organising themselves to have a roster, really, and centre in one two-storey purpose-built ambulatory care centre. I must say that in the day, the urgent presentations are seen by a nurse practitioner and then referred on to, the specialty type GP interest, depending what that might be within the practice group. So this is a large practice group. And it became, if you like, a focus for a 50,000 population outside. So it was, they had their own ultrasound, they were getting their own radiology, they were actually wanting an MR.
Yes.
Just one quick thing about Aboriginal patients is that the current guess is that Aboriginal patients see GPs at about half the rate, maybe 2 visits a year. So presenting at the same rate as the general population already says they're also underrepresented really in that, given the level of illness. So it's interesting, but also you can see the numbers are small, which is the case in Victoria relative to the rest of the population.
Can I just draw you to a close? Unless there's somebody who can guess.
I'm Andrew Walby, I'm the Director of Emergency at St Vincent's, and I was particularly interested in this group, the vulnerable, because you've left out the homeless and you've admitted that you haven't included mental health and some of the elderly, and we have a very large Indigenous population. Sorry?
Core business.
Core business. So, do the homeless have GPs? I don't know.
We do, in the full report, we did make presentations, given that I did come and talk to St Vincent's and know of your programs and the focus of homelessness, especially for the inner northwest Medicare Local region as well. All we could do is actually look at the data that said that somebody was homeless or that they lived in a boarding house or those other forms of unsecure housing. But again, that comes down to how that's coded in the VMD, and the numbers are small, and your programs actually probably have a greater wealth of information than what we can get out of the data. And I would probably, from the data, I could guess that none of those that were homeless had a GP, and they definitely weren't referred by a GP.
So my final question to the panel is, having seen this data, what happens next? You're defining the problem that you see most clearly, and what happens next?
I think for the Medicare locals to sort of ramp up and continue the work that's been started in some areas, particularly around bundles of cohorts. So we've started that work in terms of diabetes care. I think actually the sort of cross-sectorial and system thinking and planning, a bit like this excellent discussion tonight, to start to think about the longer-term planning is really important.
So really the emphasis is on core business of primary health care.
Yeah.
And secondarily, you'll solve some of the problems through the presentation.
Yeah.
Mary?
I'd like to be able to wave a wand and improve the levels of communication across everyone. So I'd like referral letters from GPs to have more clinical information. I'd like communication on discharge from EDs to be clearer. I'd like there to be an easy access for GPs to get patients into hospital in alternative modes, so direct to the specialists or urgent outpatient appointments rather than having to go to ED as the only option.
And what about appropriateness?
I think that if there was a good referral process, that would weed out appropriateness, because the letters would be good clinical information. I mean, I think ideally I would say, if in doubt, pick up the phone, talk to the registrar, decide what's the best route, but don't assume indeed it's the only option.
Registrar of Sandy was quite generously offered to provide. Correct?
I think there is a role for a short-term solution or an interim-term solution. I think this after-hours plan, even though it may be addressing a problem which is short-term, hopefully, I think it is needed. So I think is a bit of a pressure point at the moment. But long-term, I would hope much more vertical, integrated disease management through a general practice network is where we will get the biggest bang for the buck for the community.
Christine?
I think there are obviously a number of issues being raised, but I think probably from where I sit, the one would be to continue the concept of better links with our secondary hospitals and with general practice, particularly the large general practice out in the community, to support the care which can be given very adequately out in the community. I think that's probably the key issue. I like the idea of the urgent ambulatory care centre. I just wonder if there's something in that as well.
Okay.
Well, we have regular chief executive meetings across local Medicare. I think the local Medicare organisations have been great in bringing that together. So I think we should discuss this, but I think personally at Royal Melbourne we'll be taking away the direct access by phone and perhaps enhancing the assessment centre for those patients who are, they want a quick opinion on from general practice.